Good morning. My name is Gretchen Wortman. I am Vice President for Policy and Program of the National Minority Quality Forum and Director of our Institute for Equity in Health Policy and Practice. Our policy briefing today will focus specifically on the potential of the All of Us Researcher Workbench to advance efforts to diversify the clinical researcher cohort in the United States. I am joined today by Dr. Elizabeth Cohn, PhD, Rudin Professor of Nursing and Associate Dean for Research at the Hunter Bellevue School of Nursing, and by Dr. Sheldon Fields, Research Professor and Associate Dean for Equity and Inclusion in the Ross and Carol Neese College of Nursing at Pennsylvania State University. To set the stage, I would like to take a few minutes to provide an overview of the All of Us Research Program. The National Institutes of Health, through the All of Us Research Program, seeks to gather health and lifestyle data from 1 million or more US residents to inform a longitudinal cohort study that will be operational for at least 10 years. All of Us, which entered our consciousness as President Barack Obama's Precision Medicine Initiative, is an effort to enable more precise research that can lead to more effective therapies and thus reduce patient risk for ineffective or less than ideal care. The funding for the All of Us Research Program, up to $1.5 billion over a 10-year period, was authorized in 2016 by the 21st Century Cures Act. Of particular interest to the National Minority Quality Forum was the objective articulated by NIH Director Dr. Francis Collins, that at least 70% of the participants in the All of Us Research Program will represent populations who are historically underrepresented in biomedical research, HUBR. These HUBR populations include, but are not limited to, ethnic populations other than white non-Hispanic males, LGBTQ plus individuals, women of color, and individuals who reside in rural or non-metropolitan areas. The All of Us Research Program, therefore, continues to represent a pathway to eliminating barriers to increasing the diversity of the population cohorts that are included in healthcare research. More importantly, perhaps, the resulting new science can serve as the foundation for the precision and innovation that is needed to bring new therapies to market for populations and for conditions for which there are currently no efficacious or safe therapies. Simply put, the All of Us Researcher Workbench has great promise to improve care outcomes for what truly can and should be all of us. But we're not there, well, not yet. Our discussion today is intended to open the door to an articulation of real or perceived structural barriers or other hesitancies that may impede the All of Us program's constructive engagement with the researchers necessary for our future. Drs. Cohn and Fields will share their perspectives and are open to addressing any questions you may have. Specific questions about the data use and registration agreements that are required to access the data in the Researcher Workbench will be referred to the All of Us program staff. Throughout this briefing, please feel free to enter your questions into the Q&A box. The Q&A box, not the chat box. We will not monitor the chat box for questions. We will attempt to answer as many of your questions as possible after our presenters have completed their opening statements. And yes, I also have a few of my own. Dr. Cohn, you have the floor.
So thank you so much, Gretchen, and to all of the participants and to Dr. Fields, my fellow panelists. And thank you to the National Minority Quality Forum and the Institute for Equity in Health Policy and Practice. I have long admired your work the integrity and foresight with which you do it, and the well-deserved respect and admiration in DC and across the nation. We are truly grateful for the work that you have done. We share a bold vision of health services, research, delivery, and financing to improve the quality of life, especially for people who have not benefited from research in the past. So, a short introduction of myself. My name is Elizabeth Cohen, and I'm a nurse and a nurse researcher at the City University of New York. My mission, like yours, is to assure that we have sufficient representation in research to close the gaps instead of widening them. Because there is a danger, especially in emerging types of research, that if we advance health for some, but not for everyone, that we can widen existing gaps and exacerbate health disparities. I'm currently the author of the Principles of Community Engagement. It's now in its 30th year. And I believe that health is a community level factor that involves where we live, work, pray, play, and all of that affects our own health and wellness. I've worked in the Harlem community with my primary partner, Abyssinian Baptist Church in New York City, and an organization that I helped to start 16 years ago called the Communities of Harlem Health Revival, which is a faith-based and community-based organization that works to improve the health of people in Harlem from river to river. Today, we're going to discuss the All of Us Research Program, which launched from Abyssinian Baptist Church 6 years ago. Francis Collins came to New York City and launched it from the church itself. But I wanted to give a little bit of background about the program and how this research program supports the mission of NMQF, of optimum care for all, and assisting healthcare providers, professionals, administrators, researchers, policymakers, community-based organizations, and people in general to use research and data to lead a healthier life. So I want to take us back a little bit in time. Before we launched this effort, Gretchen, I don't know if you were a part of it, but I know that the National Minority Quorum Forum was. We brought 200 community organizations to Bethesda, Maryland. It was the first time NIH had ever sponsored anything like that. And people have often asked, do you ever hear about, do you hear about or do you think about trust? Do you think about things that have happened in the past under the name of research that have been anything but research? And what about transparency? What about safety? And we think about all those things. We have thought about it from the beginning, and we think about it today. So I'll just say that this, as Gretchen said, this is part of a White House effort under the Obama White House that split off. One was the Precision Medicine Initiative, which has become All of Us. The other one became the Biden Cancer Moonshot. Both of those are still in existence today. And the All of Us is a 1 million person, longitudinal, disease agnostic. So anyone can enroll. No age limitation, except no pediatrics yet, cohort that reflects the rich diversity of our nation. 1 million people is too small to be representative, but it can be reflective of people who have not had the benefit of research before. And as you said, Gretchen, LGBTQ, gender and sexual minorities, racial and ethnic minorities, rural populations, a specific focus on that. Why is that? Because in the past, the research cohorts have been made up primarily of white men. And when they haven't been white men, they've been white women. So that doesn't advance health for everyone equally. And so this was one piece of trying to advance health more equitably for all. But in my work, one of the most important things about this is that it is small d democratizes the data sets. So prior to this, there have been large national programs that have not been easily accessible by minority-serving public institutions. The data has not been broadly accessible. This allows institutions like the City University of New York to do cutting-edge research. We would never be able to recruit 1 million people on our own, but through the use of this public but safe data set, we can do the type of cutting edge research that minority researchers and public health university researchers are capable of, but never had the resources to do before. And then I have a small project that is linked to the All of Us project that brings researchers, non-traditional researchers to the Workbench. we ran, it's called a data sandbox, and we do it in like a fun way with introducing them to the workbench, and then a data treasure hunt that helps people find relevant data. We've done them for nurses, we've done them for community-based organizations, social workers, people who specialize in LGBTQ research. And we actually are launching one for journalists to help them fight misinformation by using actual NIH data that they themselves can reference and look at. So part of the work of that grant is to better understand what people need to use this data set, and indeed where they would like to use it. So we have a collaboratory in Midtown Manhattan, but we also can pop up a research hub in your hospital, in your community-based organization, in your workplace, to see if maybe if we bring data to people, will that actually help even more. So we are testing these models. We're determining for NIH what people need in terms of supports, and then where they would want to work and the types of questions that they would want to ask. Because ultimately, we have to show, researchers have to show, and NIH needs to see how a data set like this that's majority minority can improve health. Because if we're not improving the health of our nation, then we need to make it so to deliver on the final promise of the program, which is that the data will redefine how research is done and improve health and engage populations through this to really transform both research and health in our communities. So I think maybe I will stop there and turn it over to Dr. Fields.
Thank you, Dr. Cohen. Dr. Fields?
Yes. Good morning, everyone. And I too would really like to first start by saying thank you to the Minority Party Forum and the Institute for Equity for providing an opportunity to have this discussion today. I'm always humbled when I'm asked to participate. And I'll start out by also just saying a little bit about myself as well. You know, I am first and foremost a nurse, trained as a nurse researcher, a health policy specialist, a advanced practice nurse. I've been a family nurse practitioner for over 25 years, an educator and administrator, and more importantly to me, a social health justice advocate. And those are all of the lenses that I look through when I look at a project such as this. And I have been involved in the All of Us research project through two different ways. First, I've been a part of the education and the encouragement of enrollment through the work in a subcontract to the National Black Nurses Association, which is a national partner, community partner. And I currently serve as the first vice president for the National Black Nurses Association. My second major involvement with the research project, in full disclosure, is as a participant. I actually enrolled. And I say that because I think it's really important. And I think it lends a certain amount of legitimacy to the rest of the comments that I will be making. Because as somebody who's been doing this type of work for a very long time and trying to get access to research and trying to instill research into historically underserved communities and populations that have been historically disenfranchised, and hence really does understand the hesitancy that a lot of minority populations that have been taken advantage of resist with enrolling in these types of major governmentally sponsored clinical trials. And that's really what this is. This is a huge governmentally sponsored project. So for those of you who think, well, why should I participate? Well, it's your tax dollars at work. So I suggest you jump on in here because you're going to pay for it anyway. And this type of database, as Dr. Cohen mentioned, is something that is unprecedented in the way in which they've approached over sampling or making sure that we not only enroll, but probably over enroll those populations that have historically not shown up in long-term databases and research like this. So I won't go over, the long-term history in what we've learned from, the Tuskegee syphilis study, or as my friend says, the United States Public Health Service syphilis study, because it's more adequate, or the atrocities, with Henrietta Lacks. We know that. But one of the things I do want to say is the approach that all of us has taken to, as we know needed to be done, was we needed to not ignore those past atrocities, but we needed to address them. And we really needed to talk about them in a way that was respectful, that honored it, and that allowed us to begin to have conversations to move beyond it. And without that acknowledgement, I don't think we would have been here with the number of enrollees that we have gotten to at this point in the project, as well as the step of getting to open up the database to actual researchers at multiple levels. So we're not just talking about giving access to those researchers that have been what I think about as over-resourced for years. And you think about large academic educational institutions, such as Johns Hopkins and the like, that has always had access and millions of dollars in research grants and have had disproportionate access, if you will. But this database was meant to be free and have access by researchers at second tier and third tier research institutions, not only the research one institutions, insert, many big institutions, but even to encourage research from up and coming future scientists, postdocs, those students that are even at the undergraduate level or graduate level or pursuing their dissertations, to really have access to a database of this high quality and representation. So that was the goal. So the question that I have and always in the back of my mind is, how are we doing? So here's my thoughts on this. And I know we're going to talk more about this, but I do not think, and I'll be very, very blunt, I don't think that we can ever do enough to get this type of access into the hands of those who have historically not been able to have access to top quality data like this, to ask some critical questions that are generated by the communities that have been involved. Because a lot of times research questions are imposed on communities. They're not generated by the community. So the interest is to be assumed what the community is really looking to get out of a database such as this. And I always want to flip that script. I want to give people access. I want to give it to that bench, that community bench research scientist that might be working even at a community college that is so closely tied to a community that they really do understand what the needs are and how this database can be leveraged to answer critical questions that really does affect that community. Everything from climate control and environment to local incidences of any level of disease. Because when we start to do that, and we start to realize that there is value in allowing people at that level to have access, but we cannot just simply open up a database and say, hey, here it is, go at it, without providing some structure, some mentoring, some resources, because this is about resources. As Dr. Cohen said, this was an allocated budget of billions, not millions, billions of dollars. And we need to make sure that those resources are really undergirding the primary purpose for giving people access and for allowing people to get the training that they need to be able to utilize the databases. So not everybody has data entry skills, not everybody has data analysis skills, or even access to computer programs to run that data. Not everyone can be able to interpret that data without the use of, a biostatistician or someone else to assist them. And this is what I mean by resource allocation. And we need to provide those resources according to need. That is equity. And I always hear Dr. Kamara Jones in the back of my head. If we're going to do equity, we got to provide people with the needs according to what they need. I'll also end my comments there, and I really look forward to the questions that our audience has to propose to us today. Thank you again.
Thank you, Dr. Fields. I think one comment before we move to the questions is that as you and Dr. Cohen were speaking, it occurred to me, and this is more of a statement than a question, that either the population cohorts that we define as HUBR or the geographic locations that are the communities that are underrepresented in biomedical research are rapidly, based upon the US census projections, becoming the statistical or the geographic home of the majority of the collective new majority of the United States. And so failing to assure that the science that is being created supports these minority populations is essentially creating a minoritized population that by sheer numbers, collective numbers, is the majority of the population. And I think reinforce your reminder to everyone, whether a researcher or a potential participant, that these are funded by tax dollars. And they will support the health of those who engage either as participants, but I would say most importantly as researchers, to assure that that broader lens that informs the research questions that are designed and then can pull through into the development of new therapies, to assure that we are included in an empowered way. And so with that, I don't know if we have haven't had a chance to check the Q&A, but I will say that for the two of you, and I'll start with Dr. Cohen answer first and then Dr. Fields. Is there anything that either of you think that all of us can or should do to create incentives for researchers to engage with the researcher workbench? And I would suggest that you look at it through the lens of not just nascent researchers, but experienced researchers who may not think of themselves as the audience for the workbench. And starting with Dr. Cohen, please.
Yeah, so the question of incentives, I think the question of incentives to use the workbench is super important. I almost see it as a combination of what Dr. Fields said and this question, more like supports in addition to incentives. So I'll just say from a researcher standpoint, so I come from a R1, a large R1 institution, and I'm here now as a professor, endowed chair at the City University of New York. And as Dr. Field said, and as I have said, we have been locked out of these large data sets for decades. And as a result, there's almost two tiers of access, research access. There's R1 institutions who are all participating in programs like all of us, but exclusive to the IVs and sub-IVs. And then there's the All of Us program that now provides access. So it was meant to level the playing field so that every institution, and by the way, I'm a mentor for minority scholars in this program going into year 2, and I mentor high school teachers here in New York City and the Bronx to use this data set with their students. So I think one of the things that we could do to incentivize people is to let them know that we have not ever had an opportunity like this before, and that this isn't, I would never be able to create, there's 550,000 people in this nationally in this program right now. I would never, as an individual, if I was able to recruit 550 people, that would be a lot, but I would never be able to recruit 5,500 people nationally for any reason and have all of their medical records, all of their lab results, all of their Fitbit data. It would be impossible. So this is a platform that people can use to accelerate their own research interests, right? So I have a high school teacher working with 2 high school students in the Bronx on cardiovascular disease. I have a minority scholar at another institution, not my own, working on ocular hypertension. We would never be able to have these types of projects that will, and in the ocular hypertension one, she's just identified in this data set that Blacks and African Americans are more prone to ocular hypertension. So she's doing now a concerted educational effort around increased screening. So I think the incentive here is that we can do the research that we want. The platform is there for us to use, and it's our job, NIH's job, my job, to determine what kind of supports are needed. But I think what the best incentive will be the power of doing your own work in a data set that supports it, of people who have not been served by research in the past, for all the reasons that Dr. Field said, for us acting for research being done irresponsibly, egregious acts against all types of minorities, and etc. So let me let you take a stab at it, Sheldon.
No, absolutely. Thank you. So you asked what incentives can be done. So when I look at researchers, I think about myself and my other colleagues that have historically have not been able to compete and obtain the same level of research funding through NIH for years. And they know this. Well, even though we have the training, we are still somehow disenfranchised, or have been. So there are a cadre of researchers at all levels, some of us senior researchers, that should be given different access or to resources. So we need to build research teams that are for us, by us. That's important. It's really important who's leading these teams and who are asking the questions. So they need to take those resources and they need to be able to provide a mechanism whereby those that are teaching at historically Black colleges and universities, Hispanic-serving majority institutions, and Indigenous and tribal colleges, to directly fund those senior researchers to work with their students. Because I think there is such richness in what students at all levels will bring to this, things that we don't see as senior researchers. You know, because as much as I would like to think that I have an open mind about everything, I'm not naive enough not to know that, one, I'm not a digital native. So they come with even different ways and views and mechanisms to even think about how to use this data, disseminate it, that I will never be able to do. But I can also learn. And when you talk about involving senior researchers and building teams, you got to be able to provide for people's time. So part of that incentive is being able for people to buy themselves out of some of their course or administrative work that you know we're otherwise also called to do, and that as minority faculty, we're overtaxed because you know we already do a great deal of things that we are never compensated for by all of these institutions where we work. particularly any minority faculty member that works at a majority PWI institution. But more specifically then, those other types of institutions have always been seen as lesser than. And it's time that that type of well, scientific nuances just simply has to stop. There are valued researchers at those other types of institutions, and we need to incentivize them with the dollars to build those research teams, access the database, and to be able to really utilize it in the way in which the rhetoric about all of us dictates it should be done.
So, Dr. Fields, could you expand upon that a bit in terms of how a pathway that you may envision that would enable NIH to implement what you just recommended?
So a specific call, a specific perspectives that allows, or I don't like the word target, that focuses on minority researchers as senior researchers and mid-level researchers to build small research teams. Because again, I'm a big proponent of working in teams. Yes, that some folks do really well as sort of an individual solo scientist, but I think this database has so many nuances to it. And if you're working in a team, there's somebody who's going to see something that you don't. And it can be set up based on any particular disease entity of interest. My personal long-term interest was always in HIV prevention and human sexuality. And this database even does touch on those issues and issues of chronic disease, which, you know, a focus, intentional, that's the word I'm looking for Dr. Wortman, intentional mechanism of funding that shifts resources and dollars to those institutions, I think is what NIH can easily do.
So I was writing, so I couldn't respond to you initially because I think you've highlighted sort of the what I would say the trigger to that will assure that success is achieved, and that's intentionality.
Intentionality.
And not only for NIH and All of Us research program, but what we've heard in past gatherings from researchers who were working in PWI institutions, predominantly white institutions, but it may indeed be an issue in other HBCUs and other institutions, is that having their voices heard, getting agency within those institutions so that their research moves up the chain, I assume is informed not only by the politics of the individual institution, but some external factors as well. And for those researchers, I would ask both you and Dr. Cohen, to speak to in that sort of intentional perspectives that NIH, we may be able to encourage NIH to create. How do you influence that behavior within and across the individual institutions? Because for most of us, it's invisible. We don't see it, we don't hear about it. The purpose of this sort of series of policy briefings that we're holding is, to a significant degree, give voice to those researchers external to this panel who are thinking it, but for whatever reason may not feel comfortable asking the question right now or associating themselves with the question. So I'm just going to stay with that issue for a moment. How do we break through that culture, the academic research center culture that I think is to a significant degree the comfort zone for NIH. How do we break through that? And at the same time, enabling those who have advanced within that culture to embrace it rather than to feel threatened by it. Now, I'm not asking you to save the world for us here, but it's occurring to me based upon the different conversations we hear that that's a significant part of the problem, sort of status quo in the establishment versus what is here and now in terms of changing population demographics, that including but not limited to the researcher cohort.
So I'll jump in because as you said that, one word came to my mind: intentional collaboration. Because don't get me wrong, I was educated at one of those PWI Ivy League schools, i.e. the University of Pennsylvania. So I don't disregard them, but I do think that their time of disproportionate resourcing should come to an end. So if you write an NIH proposal that intentionally requires that those top tier institutions, as part of their proposal, must collaborate with a second tier research institution, an HBCU, an historically Hispanic-Serving Institution, indigenous and tribal colleges, so that there is purposeful mentorship, because those top tier institutions have much to offer in training for those other institutions. So get those teams working together in a way that gives the appropriate amount of resources, that has access to the training that other people need, and to statistical experts, design methodologists, and theorists. That's how you do it. That's how you do it. You require it in whatever that RFP NIH designs. And when they design it, I think they should also call people like me to help them do it.
I think it's a great idea. Dr. Cohen?
Yeah, I'm still processing a little bit. I think we're at an inflection point, and I think NIH is at an inflection point. So my husband likes to say another overnight success 38 years later. Like, some of us have been at this for a very long time, and sort of our time has come. NIH is considering a number of mechanisms. Compass is one of them, which funds directly to community organizations. I currently have a large center grant with Columbia, Cornell, Hunter College, and Health and Hospitals PAGNI that does some of what Sheldon is saying. It's definitely a rocky path, but we're on it. In a community transformation grant. So I think NIH is trying. I think what we're seeing at the front line is a lot of people kind of jumping into the space without a lot of the direction, or even going back to what we said in the beginning, acknowledging the past, appropriately acknowledging the past, thinking about things. So we have a lot of questions. We have a lot of questions from community organizations about how power sharing really looks, how co-funding really works, how data collection around things like domestic violence or food insecurity, what are our obligations if we're asking questions like that? What are our obligations to communities to help? The line between what used to be a line between research and clinical care and service has been, I think, thankfully, intentionally, I would say blurred, but I think it's actually porous. Things are going back and forth now in a much more robust way. So I think we're seeing a new emergence of this type of capacity building, this type of research, these type of opportunities. I know that I was the lead author for the Research Center for Minority Institutions mechanism at Hunter. We didn't get the grant, but there are mechanisms at NIH that they're actually looking at now, if they can make them even more robust to better fund some minority serving, historically Black serving institutions. The mechanisms are there, not as much as they should be, and often not designed the way that we would at nurses would say on the sharp end. We're on the sharp end of this, but maybe not with that design. But I think there is definitely an inflection point happening. So discussions like this now are exactly what we should be doing and having. I sat as part of under Shannon Zink at the National Institute for Nursing Research. I sat as part of a work group to try to see what can we add to calls for proposals that would help. So to your point, that partnership, a representative from the community piece. And I would say as an aside, what we're doing here is not just bringing a community member to the research table, but flipping the model so that we put a researcher at the community table, which I think is really where we should be going. A researcher at the clinician table, a researcher at the community table. Never mind them coming to us. That never worked. We used to go to them anyway, but certainly those times are over.
Yeah. Well, I mean, I want to say something more. One thing that you said, Dr. Cohen. Dr. Wortman, representation matters, and I want to just make this really quick point because I'm not going to say anything here that I have not said to Dr. Zink personally. And as a nurse who is a researcher, the National Institute for Nursing Research had never really had a robust, focused agenda that assisted the progress towards health equity in using an anti-racist praxis, the way in which I think this database allows us to. That research institute has only ever been headed by white women. And it's emblematic and problematic of what the nursing profession has done. So, one of the things I said at the very beginning, as I introduced myself, I'm a nurse. And that is one of the lenses that I look through when I think about everything that we're doing. No one, most trusted profession in the world, and those of us who have a lot to bring to that table, and particularly as we focus, quote unquote, on health equity as directed by the 2020-2030 report on the future of nursing. And I do think that the profession has a lot to offer leveraging this database. And I really want to do that, leveraging the National Coalition of Ethnic Minority Nursing Associations, which includes, the National Black Nursing Association, Hispanic Association, the Filipino, Asian American Pacific Islander, and Onondaga, the Native American, Native Alaskan. But representation matters, just like representation matters at who heads these research teams. And I want to be really clear about that minority researchers have not been given their fair share of access and resources. They never have. And I hope that we don't continue to perpetuate this type of situation and be more intentionally anti-racist as we develop these programs to do access to this research database.
So thank you to both of you. And I don't see any questions yet in the Q&A, so I'll keep following this train of thought. It occurs to me that I think while both of you have very effectively articulated reasons why researchers who care about these issues should engage with the researcher workbench. That requires two things. One, I think, is finding a way to encourage their institutions to undertake that data use and registration agreement process to open the door for access to the researcher workbench. But it then also occurred to me that maybe part of the challenge is, and I don't know what the numbers look like now in terms of sort of diverse researchers engaged with the workbench versus white non-Hispanic. Is the messaging regarding the potential of the researcher workbench and those researchers, does it fly counter to what we're asking people to do? Because what we may be suggesting, and forgive me for thinking out loud here, but it's a message I'm getting, which is that the populations, the researchers are not considered top tier by virtue of our societal challenges, or by virtue of the hierarchy of certain institutions relative to each other in the country, the tier one issue, the Ivy versus, I think, sub-Ivy that you use, whether or not there is a market, there's value in the work that we're asking these researchers to undertake on behalf of this collective, the majority of the country, so that it becomes part of the research delivery and financing enterprise in this country. We're not asking people, I think, to sacrifice on behalf of the greater good. We're trying to find ways to bring them into this industry that can be redesigned and must be incentivized to work to the advantage of all of these different population cohorts. Because I'm also hearing sort of community versus sort of researcher versus community, which I find interesting, because if the researchers in the institutions that our brick and mortar institutions inside a community don't think of themselves as the community, then we have an interesting challenge as well. I don't think it is insurmountable, but I think it's important that we recognize the sort of front line messaging, but also sort of the subliminal messaging associated with how we're describing these issues. So I will open that for reaction to either Dr. Cohen or Dr. Fields.
Dr. Cohen?
I was going to wait for you. So I think you're exactly right. I do think that I think that that research needs to improve the health of communities, broadly defined, or we're not really, that it really isn't a responsible, like research for research sake, research for publication of papers sake isn't enough. It needs to improve health. It needs to demonstrably improve the health of communities. So how can we generate those questions, and then how can we create, as you would say, Gretchen, the pathway? I think that's really a key. Those are key questions among them. So just to take it apart for a second, I would say that we will let you know after November 7th. We're doing this data sandbox for community-based organizations, showing them the public data browser and talking about how this data might be incorporated into their own community organization. And then we're actually pilot funding them with $35,000 to $40,000 each to show how the data can be used, how using the data to guide their work could improve community health at the community level. And that right there is a model of using finding the people who are already doing the work and supporting it with the data. I think sometimes we use the data and then we try to use that to do the work. But here we're kind of taking a new approach. So that's the one part. On the researcher part, how do we create that pathway? Sheldon talked partially about it. I think the tiered system, the academic tiered system, is real. I came from an institution. I didn't know when I was at a Research One institution how strong the headwind was. But when they took it away, and I was at the City University of New York, and I could move more easily into the community and have those discussions and have that research respected, it made a huge difference. So I think that's a real and a valid concern. I'm going to let Dr. Fields answer it, but I want to push back on one small piece of this to better understand it for myself. So let me do that. Let me give you the floor, Dr. Fields, and then let me ask you a question about kind of what you're positing.
So, okay. We've known about the concept of community-based participatory research for a very long time. And it really is sort of generating those research questions or a research agenda that includes those targeted communities from the very beginning of the research design. And a lot of research was top down, as if, Ivy League educated researchers always knew better. And even in thinking that the gold standard of, the double-blind clinical trial, had to do, with everything, and not taking full advantage of the different types of and modalities of research, mixed methodology, qualitative and quantitative methodologies. And I'm a very big proponent of taking that research out of the Ivy Tower. It's how I was trained as a researcher. It's how I look at my own research. And there was a question that was in the Q&A, Dr. Workman, that asked me for an example of when minority representation mattered. So in my own research as an HIV/AIDS prevention research scientist, when me and a couple of my colleagues developed a HIV prevention trial network study, HPTN 073, that really talked about how do we incentivize getting PrEP into a highly affected population, which was Black men who were at risk for HIV through having sex with other men. We stood up the first minority-led, fully led HPTN study in that institute's history. And it did matter. The retention mattered, the recruitment mattered, the methodologies mattered, and it was a very successful study. You can look it up, HPTN 073, just type it into your browser to come right up. So it does matter. It matters to the participants. It matters to undergirding a level of trust in the process. Because one of the other things that the NIH All of Us project is really doing, which I think has immense possibility, is the DNA and genetic testing that is also being done in the project. But now you're talking about things that is really scary to a lot of people, because how is that information going to be used? Can I trust this study that it's not going to somehow be used against me? And is it really going to be helpful? And I think we need to do a much better job of explaining the mechanisms of genetic results that are going to now starting to be coming out that participants are going to be getting. And again, remember, I told you all I'm a participant in a study. I got a letter that explained to me what was coming up with that release of genetic information. And even as a PhD educated researcher, I found the letter a little concerning. And it generated a few questions, even on my own part. So if I'm sitting here with those questions, I can only imagine what lay individuals are thinking. So we've got a bit of work yet to do, particularly with that piece that's coming up. And I really wanted to make sure I mentioned that and address the question that I had seen in the Q&A.
Thank you. There's another question in the Q&A. What does the process look like? And maybe you've answered part of this already, Dr. Fields, to be sure that the evidence generated includes questions, concerns, and objectives of the focal community, and that this is a challenge. I'll give you both an opportunity to respond to that.
Maybe I'll take a stab, Sheldon, if that's okay. So so I think this is a really good question, and I want to say a few things that maybe we haven't said already, and I don't think they've been said on previous calls, but I'll make them short just in case they have. So the data is national and longitudinal, and it doesn't ask any questions. The people asking the questions are you all. It's me, it's Sheldon, Dr. Wortman, it's you. We're the ones who are asking the questions. But the data, because it's collected longitudinally, means that it's surveys, it's medical records, biospecimens, genetic results, as Sheldon just said. So we are the ones generating the questions. The problem is that the data is already collected, so you can only ask about it in its collected form, because you're not going to send a survey to individual people. You have to rely on the surveys that have been previously sent. And there's 3 tiers: a public one that you can look at right now at researchallofus.org or researchallofus.gov or whatever it is. We'll put it in the chat. And then there's a registered tier, and then there's a controlled tier. And each one of those have increasing levels of privacy protection and increasing levels of registration protection on the investigator side. So you have to provide more and more information. At the public data browser, you don't need to provide anything. At the top tier, you need to provide your institution, your ERA Commons login for NIH. You have to be a registered researcher. They'll track you in the cloud, in the data analysis part. So I think I just want to say that this is a platform that enables research, but it doesn't do any research on its own. So the more people that we can bring to the data set that ask questions about health equity, the more health equity research we will have. Oh, thank you. The more health equity research we will have. So that's really to bring us back to the beginning of where we started, that the idea of bringing more minority researchers to the workbench is the idea of asking more questions. I do not dispute anything that Sheldon Fields said. I think everything you said is right on target, but I want to ask one question about it. So many, many, many years ago, about 1 million years ago, I had a large CDC grant. It was the first grant that Columbia University ever got with all 4 schools: dentistry, medicine, nursing, and public health together. It's going into something like, 16th year now. And the coordinator of the grant and I went out to dinner in Atlanta when they launched the grant. We all went to the CDC. And he point blank asked me, what's the deal with like a white person doing disparities research? Like, what is that about? And so I wanted to ask this group. One of the things that I said at the time, and I believe now, is that the health disparities in this world are way too great to put them on any one person to solve, or any one. I agree with minority-led teams 1,000%, but I also think that's a lot of responsibility. And there could be minority researchers, or in our case, it was public health. The grant was for public health educators. There could be doctors or nurses that want to do plastic surgery or orthopedics, or there could be minority doctors, minority physicians that want to work in a non-minority, non-health equity field. They may not want to go into FQHCs, or they may not want to work they want to do whatever they want to do. And I felt like at the time, and maybe this is wrong or maybe this is right, but I felt at the time like they should no one should be doing this work of the heart, this hard work that constantly pushes a rock that rolls back over me twice as far each day, unless they're really committed to it. And I don't think we can make that assumption necessarily. So I agree with 100% of everything that you said, but at the same time, I'm wondering, is there room in the field for everyone, or do you feel like we should just really now kind of flip it into something else?
Mhm. So I absolutely believe that there's room for everyone. So this question comes up whenever I talk about issues of social health justice and even access to certain programs and things. And I encounter what I refer to as people's pie mentality. So people think about access to resources, in this case, access to the research bench and research dollars as a single pie. And if I cut up the pie and I give you a bigger piece or somebody else a bigger piece, then that just leaves less pie for me. So now we're all fighting about this one little pie that we keep cutting up in different ways, instead of figuring out a long time ago that it really isn't one pie. We need to bake some other pies. We need to bake some other varieties of pies, some other types of pies. We need to bake pies of different sizes. So now we're all not fighting over one pie. So now I know everybody wants pie like me because now I'm hungry. But my whole point is you have to change your mentality. It is not just this one thing or one group. It really is everybody. And we really can learn from each other. But here's what I will say. We keep pretending that the playing field is equal and that we all start out with the same place. And I wish that was true. And we don't. So as somebody who has also been a researcher for a very long time, who has probably been somehow disenfranchised in a system that didn't see my value, even though I have the research training, there does need to be some incentive and some intentionality about redirecting resources and getting people who have historically been over-resourced, giving them an incentive to work with those who have not been, in the service of the same objective, which is health equity for all.
And so what I'll add to both of you is that, and this is what I'll call my Dr. Gary Puckrin moment. I think if he were here, he would say that in his view, and therefore mine, there is nothing more important than assuring the health of the human beings on this planet, because, and he researches these kinds of things for fun. To his knowledge, there's nothing like us anywhere in the universe, anywhere we found. And even if we find it necessary to leave this planet because we have somehow exhausted its ability to support life as it's embodied in us, we will take our knowledge or lack thereof to the next planet, to whatever planet we choose to colonize. So there's an extraordinary moment here, given where our scientific knowledge, our technology has taken us, and maybe the imperatives of saving the species, given the threats around us, to move this conversation forward. And I would say to those who have not yet engaged with the researchers who have not yet engaged with the All of Us research program, please do so. It requires nothing of you other than opening that door, getting a pass to use that resource should you choose to do it. I would also say, and I can say this, but this isn't speaking for Dr. Fields or Dr. Cohen or the program. $1.5 billion over 10 years sounds like a lot of money, but it isn't. It's nothing compared to what it takes to create a foundation of research that supports lives and triggers innovation. And so I opened with that number just to make sure all are aware that it's a significant amount of money, to be appropriated by Congress, but it doesn't begin to touch the resources, the fiscal resources required to assure that risk for preventable, what we understand currently to be preventable health conditions is minimized, and that treatments for those that of which we are aware are available and efficacious in all. And so we're about 20 minutes out from closing this webinar. I know that Dr. Cohen and I think Dr. Fields and the rest of you have a hard stop at 1 o'clock. I would ask in the next 15 minutes for you, Dr. Cohen, and then you, Dr. Fields, to share with the audience your take-home message. What do you want them to take away from this conversation? And where would you like this conversation to go next as we continue it?
Sure. So I think the takeaway is that I think that this has been for some of us a life goal, a signature project, our legacy, if you will. And while far from perfect, and with many caveats and places where improvement is needed, we have gotten the ball down the field just a little further than we ever have before, so that people who care deeply about health equity and health disparities in our nation have the opportunity to look at a database. It's not easy to analyze because of what it is. We don't have any other minority majority databases, so sometimes sometimes normalization curves aren't normal because the data isn't behaving the way it normally would, and that's a good thing. That's what we wanted, because we're trying to really redesign research way. So I would encourage people to reach out, to look at the public data browser, to think about how the program could help. I will provide my email and the email from my project director. We're always looking for the questions, the pathways, the places that you got hung up, and the places that you felt accelerated by the program. It does require some programming experience that not everyone has, and indeed few people have it. We know that that's a problem, but we look for other places as well. And I think it's our opportunity to continue to improve this so it does work for everyone at every level. That is the goal, and so I'll die on that hill. And we're trying to get from here to there, and so I think it can be an opportunity for us to give the feedback and to try to help mold this into something that will genuinely work. And we really invite people to use it. If people don't use it, we have not delivered on the promise of this program by any means. So use it for disparities research, use it to inform how we can have better health equity.
Thank you. Dr. Fields.
So, this is an ongoing longitudinal study, and we are not yet fully enrolled. So before I say anything, I want to say to people, enroll. Become a part of the solution or the future solution. Because when you have skin in the game, then you change your perspective a little bit. And I believe, as someone who has enrolled, that I'm able to talk with a level of validity about this that really underscores my personal commitment to advancing science, particularly that science that serves all of humanity and people who look like me, who have historically not been served well by those mechanisms. We must truly embrace, the concept of disruptive innovation. Why not do something that's different, unique, about how we approach research using such a rich database and remaining open while, using, the past to help inform, but not restrict where we go. And sometimes, we have a lot of folks that want to maintain the status quo and old traditions, but we have an opportunity here. And I don't want us to lose that opportunity. And I don't want people to be afraid or shy away. But I also want people who will push against the system, because I think that's really helpful as well. Those really disruptive innovators are going to be those that push against the system and demand that we really do address some of these historical under-resourcing that has happened in the past. Because, and again, going back to that word, Dr. Workbench, and I will always keep coming back to it, because I'm all about intentionality. Because if you don't intentionally do it, then you intentionally not do it. And you don't get a default here. Not with my tax dollars. I feel like I'm also personally, funding this study, which we all are. So let's make it work for the largest number of people that we can. And let's commit to educating people through these types of forums as to what is possible. And let's keep talking, because even if we disagree, through our conversations, we will eventually find some common ground, even if we agree to disagree. But we got to keep talking about this, and we got to keep putting it out there, because I think these types of conversations are incredibly valuable for anybody who participates. So thank you again for the immense opportunity to be a part of such a dialogue.
Thank you. And my thanks to you, Dr. Fields, and you, Dr. Cohen, for being not only willing to engage, but to be so open and so forthcoming in your remarks and your responses. And our thanks to the audience for staying with us, for enrolling, signing up and staying with us through this entire conversation and this longer term All of Us research program journey, which we hope to continue to help it fulfill its potential. If you have any questions, please contact the All of Us research program at the email address that's been included in the chat box. If you have a question for the National Minority Quality Forum, please send it to Ms. Laka Nagasa. Her email address is also in the chat box. And while we may not have answers to all of your questions, we will refer you to those who do have them or who should have them. And so thank you so much, and enjoy the rest of your day. Bye-bye.